Ladies, gentlemen, good afternoon. This class is chapter 25. We were recognizing some common causes of intracranial pathology. I'm Dr. Come from the Department of Interventional Radiology, the first affiliated hospital of Fujian Medical University. Imaging technology and imaging network. The examination of technique of brain imaging include plain film, cerebral angiography, computed tomography, magnetic resonance imaging. Plain scar film. The plain scar film only display bone and intracranial calcification and pneumocephalus. The advance in neural imaging had a remarkable impact on the diagnosis and treatment of neurologic disease, ranging from earlier detection and treatment of stroke to the more timely diagnosis of dementia from the rapid detection and treatment of cerebral aneurysm to the ability diagnosis multiple sclerosis after a single attack. Now, CT and MRI substitute the plain film for diagnosis of brain disease, and MRI is the study of first choice for most clinical scenarios. This is the anterior to posterior plain scan film, and this is the lateral plain scan film. The cerebral angiography shows the vascular structure only. We can find the structure in the intracranial. And this is the image of DSA, the digital subject angiography. It's a minimal invasive examination, which insert a catheter by femoral arterial. This is a 3D reform DSA image. It's the computed tomography. This is a soft tissue window image. We can find the hemisphere and the brain tissue. However, the hematoma and the bone is bright and this is the bone window. We can find the bone fracture, and the other tissue such as the soft tissue and the brain tissue is dark. The soft window and the bone window can display the hemorrhage and bone structure. However, the computed tomography, the CT, have some injury of X-ray radiation. This is a enhanced CT plain scan, and this is the enhancement CT scan. We also can perform the CT angiographic CTA. This is non-invasive. It can show the brain tissue and the vascular structure. The DSA only display the vascular structure, and we also get the perfusion image. It's a function image. We can find this vascular is occlude, and this area is stroke and infarction, and here the perfusion is the blood supply is left. This is image of MRI, the magnetic resonance imaging. The MRI have several parameters to display the image. This is T1 weighted image, and this is T2 weighted image. We can find the water on the T2 weighted image is bright, and the water on the T1 weighted image is dark. This is enhanced GDTPA enhanced image. We can find the tumor is enhanced, and these three image is transverse plane, and this is coronal and sagittal plane. Except the conventional T1 and T2 weighted image, we also found the MRI have some special parameter. This is encephalitis disease. We on the T2 weighted image, the CSF and lesion is both bright, and the T1 weighted image, the boundary of the tumor of the lesion is blurred. However, on the flare, this is flare image. The lesion is hyperintention and the CSF is hypointention. So the lesion is very clear on this flare image. This is diplomephilus, the fat in here. On T1 weighted image and T2 weighted image, the fat both bright, hyperintensive. On the fat separation image, we can find the lesion is dark. The fat can be separation on this parameter image. MRI have better tissue resolution and non-ion radiation, and the MRI have multiple plane, axial, sagittal, coronal, oblique, and the MRI have multiple parameters: T1 weighted image, T2 weighted image, and PD weighted image of flare, stir, enhancement, and function MRI. The vascular have some special floor void. However, the MRI is less sensitive to CT in detecting calcification in lesions and cortical bone, which appears as signal void with MRI. It cannot be used in most patients with pacemakers. This is MRI. We can display the vascular without injection of contrast agent. This is MR angiography. And also we can display the venography, the venous and venous silence. This is the MRV, MR venograph. MRI has some special function, MRI, fMRI, such as diffusion image and tensor, perfusion, spectroscopy, and blood oxygen level dependent. This is a DWI image. On the T2 weighted image, the infarction lesion is a slightly hyperindication. And on the DWI image, we can find this lesion is very bright. The MRI also can display the diffusion tensor image. We can reconstruct the 2D color maps of fiber tracts. This is the PWI perfusion image, perfusion weighted image. We can know the blood supply. This is the MRS, the single volume edge spectroscopy. This is the spectrum from the blood stem. It's a non-invasive method to show the chemical composition of blood. We can learn the chemical composition of blood, such as chlorine, chlorine, NAA, such as. Before the surgery of blood, we should avoid to injure the blood function and evaluate the prognosis. So we can perform the blood oxygen level dependent image, such as the finger movement. After the finger movement, we scan the blood tissue. We can find this area is activated. This is the red area activated. The other section, we can find the finger movement. The function area is beside the lesion, and if we resect this lesion, we should to avoid injuring this area of the movement function area. This is a table to choose the first study of image. Some patient with the acute stroke, we should use the study of the first choice is diffusion weighted image for acute or small strokes if available. The non-contrast computed tomography can differentiate hemorrhage from the ischemia infarction. If a patient suffers from headache, acute and severe, the non-contrast CT is to detect the subarachnoid hemorrhage. The MRA and the CTA to detect any risk if subarachnoid hemorrhage is formed. For some patients suffer from headache, the chronic headache, the MRI without and with contrast is the study of the first choice. The CT with and without contrast can be substituted. The seizures, we should perform the MRI with and without contrast. The CT also can substitute if the MRI not available. We should use the non-contrast CT to detect the blood. If the patient is infected, we also can use the ultrasound. The head trauma, we should firstly perform non-enhanced CT, and MRI is better at detect diffuse axonal injury, but require more time and is not always available. The extracranial carotid disease, we should use the Doppler ultrasonography. The MRI also an excellent study, and the CTA is best for pre-operation operative stenosis evaluation. The hydrocephalus, the MRI for hydrocephalus, MRI is the initial study. The CT can use for follow-up. The vertigo and dizziness, we should use the contrast enhanced MRI. Also can perform the MRI if needed. The next, we should use the contrast enhanced MRI. The contrast enhanced CT also can be used if MRI not available. The change in mental status, the MRI with contrast is the study of the first choice. The CT without contrast is equivalent. Normal anatomy. The normal anatomy of the blood is somewhat earlier to the understanding with CT than MRI. In the posterior fossa, the first ventricle appears as an inward U-shaped structure, like all cerebrospinal fluid (CSF) contains structures. It normally appears black, superior to the fourth ventricle. This is fourth ventricle, and here is the tentorium cerebelli, and here is the interpendicular systems. Here is frontal lobe, and on this CT image we can find the axilla testicle. In the inferior section, this is medulla, and this is the left cerebellar hemisphere. This is right cerebellar hemisphere. Here is basis pontis, and this black dot is the first ventricle, and here is the branchium pontis. This is temporal lobe, and internal carotid artery is a floor void signal. This is basilar artery, also the floor void is a black dot. This is a section of the midbrain section. Here is the optical chiasma. Here is the midbrain on T1 weighted image and T2 weighted image. In this image, we can find the temporal holes. Here is the temporal holes. In this section, we can find the basal ganglia. This is basal ganglia, and here is the insular lobe, and third ventricle. Here is thalamus. Here is thalamus, and Sylvian fissures. In this section, we can find the corpus callosum. This is caudate nucleus, and here is the ventricle, is the front horns of ventricle. This is lateral ventricle in here. Here is the occipital horns of lateral ventricle. This area is occipital lobe. In this section, we can find the central semi-oval. Here is the front lobe, and this is the central sulcus, and parietal lobe. It's a sagittal image. On the sagittal image, we can display the corpus callosum. This is corpus callosum. Here is the genu and splenium. Here is the optical chiasma in here. Optical chiasma on the coronal plane image. Here is the pituitary stalk, and the pituitary. On CT image, some structure is hypodense, dark, and some is isodense and hyperdense. The fat, air, and water, and chronic subdural hematomas is hypodense, and normal blend and some form of protein is isodense. The metal, iodine, and calcium and hemorrhage is hyperdense. On MRI image, T1 and T2 weighted image is different. It is different signal. The hyper intensity is the bright on T1 weighted image. The fat, the gadolinium, the high protein, the subacute hemorrhage, and the melanin is the bright on T1. And the calcification, air, chronic hemorrhage, the acute hemorrhage, the water is dark on T1 weighted image. The water, such as edema, cerebrospinal fluid, and the hyperacute hemorrhage, and the left subacute hemorrhage is hyperintention on T2 weighted image. And calcification, air, early subacute hemorrhage, and chronic hemorrhage, acute hemorrhage, and high protein is hyperintention on T2 weighted image. This is a non-pathologic calcification on CT. The calcification that may be seen on CT of the gland, which are non-pathologic. Here is the pineal gland, the calcification of pineal gland. Here is the calcification of basal ganglia. This is basal ganglia, and choroid plexus. Also, sometimes the calcification of Fox and tentorium is normal. It's non-pathologic. The disease diagnosis. How to find a lesion? First, density or signal intensity change, and the structure change and the enhancement. This is a lesion on CT image. We can find the density change. It is more dark than the normal brain tissue. And here is a T2 weighted image. We can find the signal intensity change. This area is hyperintensity. It's a normal corpus callosum, and this is the image of agenesis of corpus callosum. We did not find the normal corpus callosum. On the unenhanced image, we did not find abnormality on T2 weighted image and T2 weighted image. However, after injection of the contrast agent, we can find a lesion in the pituitary. This is micro adenomas of pituitary. Head trauma. The scar fractures. It produced by direct impact to the scar, and we can view the CT scan using the bone. We should view the CT scan using the bone window. This is a linear scar fracture. We can find the linear scar fracture is a fracture line on the bone window, and on the soft window we do not find the fracture line, and it can display the hematoma intracranial and some pneumocellulus. This is air in the brain. The depressed scar fractures. Depressed scar fractures are more likely to be associated with underlying brain injury. They result from a high energy blow to the small area of the scar, such as from the baseball bat, most often in frontal obturator region, and are usually comminuted. They may require surgical evaluation of the depressed fragment when the fragment lands deeper than the inner table adjacent to the fracture. This is inner table of bone of scar. Basilar scar fractures are the most serious and consist of the linear fracture at base of the scar. They can be associated with tear in the dural matter with subsequent CSF leak, which can lead to CSF rhinorrhea and otorrhea. They can be suspected if there is air seen in the gland and the traumatic pneumocephalus, the fluid in the mastoid air cells of the air fluid level in the sphenoid sinus. This is a basilar scar fractures. We can form the fracture line. In this, in the image of the CT, we can form the basilar fracture and the CSF leak. The CSF is leak from the fracture is leaked into the sinus. The facial fractures. CT is the imaging study of the case of evaluation facial fractures. Multi-slice scanner or allowed to be reconstruction in the corner plane, so the patient does not have to be repositioned in the scanner. The most common orbital fracture is blowout fracture, which is produced by direct impact on the orbital. That causes a sudden increase in intraorbital pressure, leading to the fracture of the inferior orbital flap into the maxillary sinus or the medial walls of the orbit. Sometimes the inferior rectus muscle can be trapped in the fracture, leading to the restriction of upward gaze and diplopia. Here is the fracture of the orbit, and the fat is trapped into the sinus. A triple fracture, usually a result of the blunt force to the cheek, and another relatively common facial fractures. This fracture involves the separation of the zygomer from the remainder of the face by the separation of the frontal zygomatic suture, fracture of the floor of the orbit, and the zygomer fracture. And fracture of lateral wall of the lateral maxillary sinus. The intracranial hemorrhage. A dural matter composed of two layers, an outer periosteal layer and which cannot be separated from the scar, and an inner meningeal layer, the inner meningeal layer infold to form the tentorium and the fox. The arachnoid, the vestibular middle layer. It is separated from the dura by the potential space known as the subdural space, the pia mater. A close applied to the brain and spinal cord. The pia mater carries blood vessels that supply both. The separating the arachnoid from the pia is the subarachnoid space. Together, the pia and the arachnoid are called the leptomeninges. The epidural hematoma. The hematoma is between the scar and the dura. The shape of the hematoma is biconvex. It is high density, it's not close sutures and with scar fractures. This is epidural hematoma. It's located between the bone and the dura. The shape is biconvex and it is the high density. And sometimes we can form the bone fracture. This is also the epidural hematoma. The subdural hematoma is located in between the dura and the arachnoid. The shape is crescent shape and close the sutures. It is more extensive than the extradural hematoma and with the scar fracture. This is subdural hematoma. Is more extensive. And also the image also the subdural hematoma. We can form the mixed density lesion. This is a fresh blood, and here is mixed with the chronic hematoma. So the subdural hematoma is a mixed density. On image of MRI, the subdural hematoma on the T1 weighted image is hyper intensity, and on T2 weighted image is a mixed intensity. In front of the lesion, we can form a hyper intensity, and in the posterior of the lesion is a hypo intensity. The non-traumatic intracranial hemorrhage, the etiology, hypertension, aneurysm, and vascular malformation. The embolic is choked with reperfusion, amyloid, and angioxy, and coagulopathies. The blood decreases the drug abuse and tumor. Location: the hypertension and hypertensive hemorrhage is predilection for areas supplied by penetrating branches of the MCA and BA. Involve the basilar ganglia from 60 to 65%, and cellulars. The acute hematoma on CT image. The factor of the image is the electron density, the imaging contrast. There have a linear relationship between CT attenuation and hematocrit, hemoglobin concentration, and protein content. This is a hyperdense on CT from 80 to 100 Hensfield unit. This is acute hematoma. There have hyperdense and with a clear boundary, and a thin hypodense edema ring. This is a hypodense edema ring and have slightly occupied effect. It's also an acute hematoma. The subacute hematoma from 3 days to 2 weeks. The attenuation and the volume diminished with time from outer to center, with a blur boundary, and the edema ring is enlarged, and with occupied effect. We can form the lateral ventricle expressed. The volume of the hematoma is diminished, and the edema ring is enlarged from the outer to the center. The chronic hematoma more than 2 weeks. The dense, it is CSF dense, hypodense, with a clear boundary and no edema and negative occupied effect. The ventricle is enlarged. This is a chronic hematoma. The hematoma in MRI is complex. The intrinsic factors is structure of clot, hemoglobin, oxidation state, and red blood cell and morphology, and protein concentration, clot hydration, and the size. Location of hematoma edema. The extrinsic factor is the pulse sequence and field strength. The change of hematoma from oxyhemoglobin to deoxyhemoglobin to intracellular mesemoglobin and extracellular mesemoglobin and hemocysteine. It's a signal of hyperacute hematoma. It is oxyhemoglobin. On the CT image, we can form a hyperdense lesion, and the fourth ventricle, the right side of fourth ventricle is filled with the blood. Also the hyperdensity. However, the acute hematoma on MRI is sometimes iso intensity signal. The acute hematoma, the oxyhemoglobin on T1 weight image is iso intensity signal. However, on T2 weight image, we can find an area of hypointensity. This is the oxyhemoglobin. And the early subacute hematoma, the center is the oxyhemoglobin and the rim is mesemoglobin. On T1 weight image, we can find a lesion. The center iso intensity with a hyper intensity rim. And on T2 weight image, the hemoglobin, the hematoma is very dark signal, the hypointensity. The left subacute hematoma or early chronic hematoma. The center is mesemoglobin and the rim is hemocysteine. This state hematoma is hyper intensity on T1 and T2 weighted image. However, on the image of the T2 weighted image, we can find a rim of hemocysteine. The left chronic hematoma with the ferritin and hemocysteine. This is on T1 weighted image is a hypo-intensity lesion, and on T2 weighted image we can find a very black signal on the T2 weighted image. This rim is the hemocysteine rim. I introduced the mass effect. First, the flattening of the cerebral sarsi. The second, compression of the lateral ventricle, and the third is displacement of the midline structures and brainstem compression. The mass effect we can find the flattening of the cerebral sarsi. This is right side and with a normal cerebral sarsi. However, the left side beside the lesion we can find the cerebral sarsi is flattened. This patient suffered from intracranial hematoma and with a slightly mass effect. We can find the compression of the lateral ventricle. This is a normal lateral ventricle. This is left lateral ventricle is compressed. In this image, we can find the displacement of the midline structure and brainstem compressions. This is the placement, its compression to the opposite side. Some severe mass effect can induce the cerebral hernia. We can form the displacement of the midline structure. The left fourth ventricle is compressed to the opposite side. The lateral ventricle is compressed, and this is placement compression to the anterior side. The type of hernia is subversing herniation. The supratentorial gland, along with the lateral ventricle and the stratum pellucidum herniates bends the forks and shift across the midline toward the opposite side. The transtentorial herniation. Usually the cerebral hemisphere are displayed downward through the incisura bends the tentorium, compressing its lateral temporal horn and cause dilatation of the contralateral temporal horn. The foramen magnum or tonsillar herniation. Infratentorial gland is displaced downward through the foramen magnum. Sphenoid herniation. The supratentorial gland slide over the sphenoid bone either anteriorly or posteriorly. The extracranial herniation displacement of gland through a defect in the cranium. Diffuse axonal injury. Diffuse axonal injury is responsible for prolonged coma following head trauma and is a head injury with poorest prognosis. In this image, we can find in this CT image we can find a little hematoma here. However, on DWI image, we can find the corpse coloration is affected. So initial CT scan may be normal or underestimate. The MRI is the study of choice in identifying diffuse axonal injury. On the DWI image, it can display very clearly the corpse coloration is affected. Increased intracranial pressure. The clinical signs, popular edema and headache and diplopia, caused by cerebral edema. Increased volume of the gland or hydrocephalus, increased size of the ventricle. The cerebral edema, trauma, hypertension, and messes are the most common cause. The vasogenic edema, the extracellular accumulation of fluid, it is caused by abnormal permeability of the blood-brain barrier. It predominantly affects the white matter. The cytotoxic edema, the cellular edema, and is associated with cerebral ischemia. Is attributed to cells death. It affects both the gray and the white matter. This is a DWI image. If there is the sodium and the potassium pump dysfunction, the cytotoxic edema is formed. This is the vasogenic edema. It's a result from the loss of cell members integrity. The stroke include ischemic stroke and hemorrhage stroke. The cerebral infarctions, the etiology, atherosclerosis, arterial narrowing and occlusion, the cardiac emboli, the arterial dissection and vasospasm, and vasculopathy, the drug abuse and the tumor encasement. The physiology, the dense ischemic core and less dense ischemic peripheral is penumbra. The sodium to potassium pump dysfunction cause the cytotoxic edema. The loss of cell memory integrity is vasogenic edema. The infarction, the pathological change is more water. On the T1 weighted image, it is low signal. On T2 weighted image, is hyper intensity, and on the CT image is low density. Infarction in CT. The acute infarction, no direct sign in 25 hours. The direct sign is low density. This is an image 2 hours from onset. This is a normal image. This is a normal density here. We perform perfusion weighted perfusion in CT image of perfusion. We can find this is ischemic area. And the perfusion by gradient, we also found the ischemia area. And CTA, we can find the occlusion of the cerebral anterior artery. This also can display the occlusion of the artery. And this is image. This is CT 4 days after onset. We can find the hypodense area and with a wedge shape. This is subacute infarction. It with the low density and mass effect. We can find the wedge shape area. It's the vascular distribution area, both gray and white matter. The subacute infarction from 25 hours to 48 hours. It with a low density and gyrus enhanced. This is a BBB disruption from 3 days to 10 weeks after we can find the gyrus enhanced after injection of the contrast agent. Here is a chronic infarction with low density and atrophy. We can find the enlargement of the lateral ventricle. Infarction in MRI. Acute infarctions. On the DWI image, we can find a hyperintensity because this is a cytotoxic edema. The acute infarctions is a long T1 and long T2 signals and with mass effect. The acute infarctions is a normal signal on T1 weighted active image and slightly hyperintensity on T2 weighted image and with mass effect. Sometimes we can find the cause of the infarction. In here, we can find ICA thrombosis. This is a normal ICA and this is a abnormal ICA with thrombosis. So we can find it is lack of the fluid void. The chronic infarctions with hyperintensity on T1 weighted image and hyperintensity on T2 weighted image. The signal is similar to the CSF. Also, we can find the drivers enhanced on the 3 days to 10 weeks. This is hemorrhage infarction. The cause is reperfusion injury. The vascular structure is damaged, so we can find some hemorrhage in the infarction area. Oh, thank you. Class is over.